Here on GameChangers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting CEimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count.
Hi, everyone. Welcome to the GameChangers Clinical Update Podcast. I'm your host, Rachel Maynard. How many times in your practice have you been faced with a question from a patient showing you a bump or a rash or a spot on their skin and asking, what is this? I know for me, that was always a tough question because a lot of skin issues can look really similar. And as our scope as pharmacists continues to expand, it's more important than ever to be able to evaluate these conditions. So today we're going to navigate this potentially murky area of practice and discuss some tips for answering those questions when patients ask. And so to do that, I'm so pleased to welcome our guest, Dr. Jamie McConaha. Welcome, Jamie.
Hi, thanks for having me.
So excited to have you. And thank you so much for taking time out of your busy practice to meet with us. But before we dive into this topic, maybe you could share a little bit about yourself, your background, your current role, and why you're passionate about this topic.
Yes, absolutely. So as you said, my name is Jamie McConaha. I am an associate professor of pharmacy practice at Duquesne University's School of Pharmacy in Pittsburgh, PA. I practice as an ambulatory care pharmacist with Allegheny Health Network, and I've been doing that for over 10 years. Prior to that, my practice site was in community pharmacy, and I also continue to moonlight in community pharmacy as well. And like you said, sort of working in community pharmacy, we would always get those questions about derm conditions. And I felt at the time, we went over some of it in our curriculum, but I felt like there was definitely a lack of knowledge among pharmacists about some of the more common skin disease states. So I actually developed an elective course now that I teach at Duquesne on common derm conditions, and we've also integrated more of that into our curriculum as well. So it's definitely a passion area of mine. I feel like with a lot of these disease states, there's a lot of changing landscape in terms of medications and things like that. So it's always interesting and an important area for pharmacists to stay up to date with.
Excellent. Well, it sounds like you have the exact expertise that we were hoping to have on this podcast. So thank you again for taking time. I think let's go ahead and just start with some of the most common skin conditions that we as pharmacists tend to see. I know that's a very broad question because it could range from anywhere from a rash to a bite to poison ivy, oak sumac to things like eczema or even fungal infections for that matter. It could be a whole scope of things, or thinking about potentially riskier things like cancer. So there's this broad spectrum. And maybe if you were to try to just how to help us think about categorizing this or sort of overview of what are these skin conditions that we're most often thinking about.
So yes, so absolutely. I feel like you said, there are so many skin conditions that patients present with, and thinking of it as sort of an ambulatory or community type of perspective, so many times patients do come up to the counter and just say, what is this rash? And it's difficult because so many disease states present very commonly or very similarly. So eczema versus even a mild case of psoriasis both may have sort of that red erythematous rash, but it could be two totally different disease states that we treat differently. And then of course some that might be a little bit easier to distinguish, like a bug bite or sunburn or things like that. So I feel like when a patient comes up, the most important thing obviously is to look at whatever they're showing you. And then sort of asking those background questions and getting a very thorough history. That's going to help us sort of maybe eliminate some of the more serious or referral type of situations, and also hone in on what we could recommend self-treatment for, or what type of counseling we can provide for that patient. So I know that's a very vague answer of just get
I know.
but there's so many questions that you can ask with derm conditions. So things like, when did it start? How long has this been here? Was it they changed a fragrance or a soap or a laundry detergent? Is that sort of maybe just a mild case of acute dermatitis, or is it something they've had longer and they've tried appropriate OTCs and it's not clearing up? And then we can sort of think like, okay, they have been using what they should be using. Now, again, can we go to a next step, or do we need to refer them on? So I guess that's sort of a very, again, broad approach of how I would start it. But I think you really have to start by just looking at it and then asking the patient lots of questions to get to the bottom of what's going on.
Yeah. Yeah. And I know when I was even thinking about what to ask, it can span the spectrum. So we really need to start somewhere. And I thank you calling out the questions, looking at it, and then the follow-on questions. And let's talk about some more of those questions, because I think that can help shape, again, where we might be going, what we might be thinking about. So you said, how long has it been going on, what they've tried or haven't tried, and helping us use that information to figure out what it might be. The location, right? Like where it is on the body is obviously something we would see, but that is another clue potentially. And then potentially other symptoms like pain or itching or discharge, that sort of thing. But maybe you have other questions that come to mind. I know it sort of follows on each other, but anything
Right.
else that we might be thinking about off the top of our heads?
I think you hit on most of the ones. The only other things I
Okay.
can maybe think to add to that list is, sort of what you said at the end. Are there any sort of systemic symptoms which might make us think, again, it's a
Right.
referral? And then you could also see, is it something that anyone else at home or they're in close contact with might be
Yes. Good
affected?
call.
So,
Yep.
some sort of infectious type of thing. But the other
Yeah.
ones, I think you hit the nail on the head with all of those questions.
Yeah. Well, and I appreciate you calling out the potentially inactive ingredients that could be causing this too, because that might be something people aren't thinking about, that it's caused by a fragrance or some sort of allergen or something. And that could be the issue too. So in terms of the assessment of outside of the questions, but in terms of actually looking at the issue, the skin issue, what are some of the features you're looking for there? How do you, again, rule in or out certain conditions based on appearance?
Yes. So I think, based again on what it looks like and sort of what they've answered to the questions we just asked them, that's going to help us, obviously identify patterns and think about what type of condition it may be. I think one of the more common ones is eczema, or atopic dermatitis. When we see patients with that, the key feature is intense itching or pruritus. So dry skin and itching, if a patient is complaining of that, especially in really young patients, if it's a
Mm.
mother, parent, or caregiver for a young child, then my mind might go sort of like that's an eczema type of thing. As you
Hmm.
mentioned earlier, what's the location? So again, if we're thinking
Hmm.
eczema, it's usually in like the flexural region, so where like skin folds sort of hit each other. So that might be one example. I think one that, is maybe more obvious just by looking at would be acne. And I think that's one we get
Hmm.
so
Hmm.
many questions on. And again, sort of thinking of the age range here, right? So this tends to be
Right.
more like around puberty, teenage years, that type of thing. So obviously you can look and see if there's those lesions. Are they inflamed? Are they, really bad, maybe bordering on cystic type of acne? What's the location on the face, chest, back, that sort of thing. Trying to think of other ones that we may see. So psoriasis also has a dry appearance a lot of time. Now there's different types of psoriasis, but the most common is going to be that dry appearance of psoriasis, so the plaque psoriasis. So sort of like the name suggests, it looks like a plaque on the body, but that also may be red and itchy, which is where we want to differentiate that from an eczema. And then, we mentioned a little bit about looking at like infectious types of things. So if it's a
Right.
fungal
Right.
infection, they usually have that scaled border, right, where it's more flesh colored on the inside. We could look at, things like poison ivy. Are they having, again, the itchiness, or their vesicles or streaks?
Hmm.
That would point us that way. So again,
Hmm.
appearance starts it based on the
I
questions
know.
and what's making it worse. Then you might sort of hone in. And when I have an idea then of, what type of condition I'm thinking, and a lot of times the patients have an idea too, right? Like they'll be like,
Hmm. Sure.
I was
Sure.
gardening outside. It's poison, I think it's poison ivy.
Hmm.
Um,
Hmm.
so based on that, then I sort of, do my follow-up assessment and try to like, ask more specific types of things to see, is this definitely the disease state? So making the appropriate recommendation.
Hmm. Another one that comes to mind is, again, the idea of a bite, something that might look like a bite. So maybe a very sort of contained, red, raised issue. And how do you differentiate perhaps a bite versus something like MRSA or something more potentially something that is self-limiting versus something that maybe needs attention?
Yeah, so that's a great one. So again, I think the history. So if they were outdoors, maybe exposed to insects, or if they even felt getting the bite, then, or if it appeared
Mm-hmm.
very suddenly, that would maybe lean
Mm-hmm.
more towards like an insect bite of things. And those are again like that small puncture, which you may or may not see, and that localized redness, some swelling and itchiness. Um, with it's something a little more serious like a MRSA or an abscess, a lot of times
Mm-hmm.
again we can eliminate if there isn't any known insect exposure, but that one we see progressively worsen over time, whereas
Okay.
a more mild bite would tend to get a little bit better. So even if they're taking
Mm-hmm.
a pain reliever or putting any sort of anti-itch cream on it, you would expect that to alleviate it.
Mm-hmm.
Whereas
Mm-hmm.
something a little bit more severe, example, again, MRSA, that would worsen over that 24 to 72 hours. You're going to get like a warm type of nodule, and that's going to be more painful.
Mm-hmm. Okay, so that's where the question around what have you tried is
Yes,
really key to see what they have tried, what hasn't helped, and that helps guide your decision too.
absolutely. Yes.
Okay. You know, w- you could spend a whole hour on other sorts of skin conditions like warts, corns, calluses, that sort of thing. That also is something people ask about, which is a skin condition, but clearly presents very differently than some of the things we've been talking
Right.
about.
Right. A little bit easier to identify for sure.
Yeah, yeah. I guess, if you between warts, corns, calluses, are there sort of differentiating features between those that come to mind for you?
Um, that's a good question. So warts obviously tend to hang around a little bit longer. So we know
Mm,
that they're caused a lot of times by viruses.
hmm
They can be a little bit, I don't, they're usually not painful, but sometimes if you sort of squeeze them from the side, it hurts.
mm,
Whereas if it's a callus or a corn, it hurts more from direct pressure because they
Okay.
develop because of friction or manipulation or like,
Hmm.
sort of repetition. So again, we see these commonly on the feet or,
Hmm.
there's that like repetitive abrasion. So
Hmm.
I think that would be one of the easiest way to identify. Um,
Yeah.
Both of them on the feet, but I think warts too. Sometimes we see those on the hands and other body.
Right, right, right.
Yeah.
Yeah. Yeah. I think the location there, like you said, that is a really good cue because again, the corns calluses are more about the pressure and that sort of prompting it to develop, whereas warts could be anywhere on the palms, feet, um, even other areas. And yeah, this also, I think, sort of lends the question of uh, cancer potentially being an issue. So any sort of unusual, maybe colorless bumps, growths. People ask about skin tags too. All of these sorts of potential growths that we don't have maybe defining features for. That starts to get into the red flag discussion and referrals. So what are some of those red flags and referral situations that come to mind?
Yes. So, with when we're thinking skin cancer, I always think of the ABCDE mnemonic that we probably
Mm-hmm.
all learned in pharmacy school. Um, we also want to refer that on, again, if it's some sort of lesion that is long lasting. So if it's not healing after, 3 to 4 weeks, a couple weeks, then definitely refer that on. If it's bleeding, crusting, or
Mm-hmm.
continuing to grow, so we always look for changes in size. I
Mm-hmm.
know, just even my own personal experience, my daughter had an unusual looking mole and she's young and it was on an area that's not as sun exposed. But, here's
Mm-hmm.
me teaching dermatology. So that, of course, is in the back of my mind. And
Right.
I even started maybe a little bit, I know, corny, but I was like taking pictures of it, like with a little measuring tape next to it,
Right.
sort of
Right.
watch the size change of that just to make sure it wasn't continuing to grow.
Mm-hmm.
Um, but yeah, I mean, I think that's sort of what I always go back to is like that A, B, C, D, E. And like you said, they can be colorless, but if some of those other features are changing, especially growth, that would absolutely be something I would want to get checked out. Even if you're referring them to dermatology and it's something they want to document and then follow over time as well. So I think you have another set of
Mm-hmm.
eyes on it.
Mm-hmm. And maybe you could just refresh us. about that ABCDE for those of us who maybe didn't learn that so recently.
Yes.
I know of it, but now I'm like struggling to think about what are each of those components. So let's just review that too.
Yes. Okay. So to review, the ABCDE rule is, again, we're looking for skin cancer here. So A is asymmetry. So if half of that mold doesn't really match the other half, so it's not a perfect circle or color is off, that type of thing. B is for border. So we're looking for an irregular border or poorly defined. C is color. So usually lesions that have multiple colors or uneven pigmentation would be a red flag. And then, as we mentioned, though, some can be colorless. So you can have like some melanomas that can be pink or a flesh colored. So you have to think about that as well. Your D is for diameter. So if it's the cutoff is 6 millimeters. So I usually tell patients about the size of a pencil eraser. If it's larger than that, that's a red flag. And then E is evolving. So that is it changing over time? So changing in size, shape, color, any of those types of things would be, again, a warning sign.
Okay. And that goes back to, I think it's a really good call out of taking a picture with some sort of, quantitative assessment there to see over time. And I think that applies even for people sort of, the recommendations are to do sort of this ongoing check, be aware of your skin, be aware of what it looks like, right? And part of that, if you have some spots like that, to be monitoring that even over years, right?
Right. Well, and I think, a lot of times, it takes so long to get in with specialists that, this is something that they do want to keep an eye on. And so, pharmacists, obviously, we're very accessible healthcare providers. So, probably the whole reason we're recording this is they come to us a lot of times to ask these questions. These are great recommendations that we can give them to, make sure you're monitoring. But if we do want to refer them, get that appointment. But in the meantime, here's what I would continue to watch for to see if it, becomes a little more emergent type of situation.
And I guess to follow on to that, so say you have an assessment of what you've worked with the patient, you have this assessment of what it might be, you maybe recommend whatever treatment is appropriate for that. And again, we can certainly talk about treatment, but I think that is challenging because the treatment might vary so widely. But maybe you can speak to that a little bit too, how you think about treatment, broadly, high level considerations. And then what do you advise the patient to be aware of and be thinking about in terms of follow up with you or with another clinician if needed?
Yeah.
So that was a lot there, but
No, that's okay. Okay, so I'll start at the treatment part of things. So,
okay. Yep.
Over the counter, we don't have a ton of options. I feel like there's a lot of over the counter products, but they sort of fall into similar categories, right? Like you have your moisturizers, you have your antifungals, you have, your acne type of treatments, that sort of thing. So obviously it would start, and your topical steroids, of course. I think it would start, sort of thinking what disease state it is. But two of the mainstays of treatment are definitely going to be moisturizers and topical steroids. And I think that's really important. This is going back to something we talked about earlier with eczema versus psoriasis. So knowing which disease state we think we're dealing with, because eczema, we use steroids, but steroids can actually worsen psoriasis. And a lot of patients, they have this red rash, and that's the first thing they want to put on it is some cortisone cream or something like that over the counter. But I also don't want to downplay the use of moisturizers. I mean, they can absolutely be a treatment. And for some of our, our contact dermatitis, our atopic dermatitis or eczema, like those are going to be your mainstays of treatment. And they can also be used preventatively for patients as well. So if we know we have a young child that gets these eczema flares, like that's going to be one of our biggest counseling points, is making sure they're using a very occlusive type of moisturizer, making sure when they're bathing, that lukewarm water immediately after bathing, sealing in that moisture with a moisturizer, that types of thing. So I don't want patients to ever think like, oh, it's just a lotion. Like they're really important in keeping the skin hydrated and really preventing some of these other, derm conditions or issues that they may present with. Okay, you're gonna have to remind me of what the second part of that was.
The follow-up the follow-up, when would you encourage somebody to either follow up with you or another provider, and some of those things to be monitoring after they go home with maybe some sort of self-treatment or,
Okay.
non-prescription care?
Yes, absolutely. So I think the first thing is, and I'm going to get to your question, but you also want to make sure they are being adherent to whatever we're recommending
Right.
for
Good
them.
call. Yep.
Because a
Yeah.
lot of these things are going to be topical medications, and a lot of
Hmm.
times patients just aren't very adherent to topicals, or even if they are, they may not use them for the correct length of time. So, um, depending again how severe their skin condition is and maybe which one it is, I think plays a role in how soon you're going to recommend they follow up. Something like an insect bite, we hopefully would see improvement quickly, whereas again, something maybe like a more chronic type of eczema or acne is going to take a little bit longer, right? For those, you usually
Hmm.
give 6 to 8 weeks of treatment before you would expect improvement. So,
Hmm.
making your recommendation for the patient, really encouraging that they are adherent to it, explain how this is going to benefit them and help them. And then based on which skin condition they have, I think really ties into how soon they should follow up again. But I think general rule of thumb, for anything really, at least 2 weeks, because if you're using topicals, I feel like that would be an appropriate amount of time. And
Hmm.
looking for
Hmm.
it's not getting worse during that time frame. Like that would mean
Hmm.
you're ready to
Right. Right.
come back sooner or follow up. But I think
Hmm.
that's a pretty conservative measure of at least seeing some improvement for most skin conditions.
Yeah. Yep. That makes sense and seems fair. And I think it's generally aligned with most OTC labels. I think they're usually like 7 to 14 days,
Mhm.
depending on the product, of course. And
Yeah.
so, yeah, that's a good sort of guideline to go by for sure, even though we're talking about a variety of different things.
Yes.
I do appreciate you calling out the moisturizer consideration too, because for many, another skin issue is just dry skin too, depending on the time of year and humidity and all of these things. So moisturizers can play a really important role. To tack onto that, how do you help a patient select a moisturizer? Because there's so many out there.
So before I started really getting into, some of the research and specializing in derm, this was a great question I often had. I'm like, I don't
Yeah.
know, what's the cheapest? What smells good?
Yeah. Yeah.
But there's actually, we do an entire lecture in our school about the ingredients in moisturizers because there's a science to it, honestly. So, what you're looking for. So, if you're a pharmacist and I always recommend to, anyone go out in the aisle, look at that active ingredient
Hmm.
list on the
Hmm.
products.
Hmm.
But you're looking for something that's a humectant. So, that's something that's going to draw water into the skin. So some of the common ingredients you're looking for there are going to be glycerin, urea, hyaluronic acid. I have trouble with that all the time.
Yeah.
But those, so like urea is a great cream. It's in lots of like foot creams, like people use it
Hmm.
for dry heels, things like that, because it does like sort of draw in that extra water. But then you want to combine that with an occlusive. So this is going to be something that forms that protective barrier over the skin. So it's going to trap that water in. The gold standard, the one we see the most is petrolatum. But mineral oil, lanolin, those are all occlusives as well. So those are like the two main things I look for in a moisturizer. So I personally, if it's a very dry area of skin, a thicker area of skin, I look for like a higher percentage of that urea. Or again, glycerin or hyaluronic acid, and then combining that with some sort of petrolatum or occlusive agent to keep all that water in.
Okay. And to be clear, that's talking about moisturizing. If we
Yes,
have a condition where
correct.
we know moisturizing is the
Yes,
solution, what we're trying to recommend,
yes, yes.
whereas when you're thinking about an occlusive in any sense, whether petrolatum or something covering a topical product, that is something we would not necessarily want to recommend if this is patients using a topical steroid, for
Correct.
example.
Yes, sorry, that
Yeah.
was strictly for dry.
No, yeah, it's again, we're talking at a very high level, so it's hard to make broad generalizations, but it's a different point to call out that when people are using a topical steroid, because we said moisturizers and steroids are very commonly used for most conditions, and it is a reminder, I think, that occlusion is not desired
Correct.
necessarily for most people using an OTC steroid
Yes,
topical.
absolutely. That is correct.
Yeah, yeah. I also appreciate how you called out the adherence consideration with topical products because proper use, whether it's a moisturizer or an antifungal or a steroid, we do want to be thinking about ensuring they're using it the way as directed on the label, again, which is going to vary. But especially like with a topical antifungal, ensuring that they're getting the most benefit out of it and the condition will be managed rather than recurring. So maybe you could speak
Correct.
to that a little bit.
Yes. And honestly, I absolutely agree for the antifungal, but the condition that comes to mind a lot for me is acne. There's
Yeah.
so many over-the-counter acne products, and a lot of them are topical. And
You're right.
really, there's only about three active ingredients in OTC acne products anyway. I mean, most of them are going to be benzoyl peroxide or salicylic acid. But if you think about the years of when this typically affects, so you get like those teenage years or, adolescent years, and they have acne. So they're going to go select, or you recommend an OTC product. They use it, and those you need to use 6 to 8 weeks. So a lot of times they're not going to be adherent to it, or they start to notice some clearing up and then stop using the product, which then, obviously is going to cause a recurrence. So I think, adherence for any disease state is super important.
Sure.
For a lot of them, it is going to be continue using for the recommended length of time, even if it looks like your skin is getting better.
Right. Yep. Great call. And the other thing that came to mind as you were just talking about that is prescription products too, and ask, because when we were talking before, I was sort of thinking about OTC, what you've tried OTC to help manage this, but just also being aware of that full medication history, what they might be using, what conditions they have, what might be contributing or not to that particular complaint. Also, something that we need to be asking about.
Absolutely. Yes.
Yeah. Yeah.
Just since we were talking about acne, there are a lot of medications that can worsen acne too. So that full med list is important.
Absolutely. And also thinking about any topical products by prescription the patient might be using, and whether that is a concern or consideration with any OTC products they're using too. Acne, again, as an example, there are prescription products that might have the same ingredients as over-the-counter products. So just being aware of that too, both from an interaction and duplication perspective.
Yes, I agree.
Yeah. So it's tough. I mean, it's tough to sort of talk about this at a high level, but maybe, we can be thinking about the adherence considerations, the proper use considerations once we've identified an issue, but also all those key questions that we're asking about to help assess and triage the patient up front. What would you say are the most common maybe mistakes that people have when trying to self-treat, or questions that come up that, myths, misconceptions? What are maybe some of those top clarifications and counseling points we can be giving to patients about proper use of and management of skin conditions broadly?
Oh, that's a good so I think one thing I've heard from, or not heard, but I've seen with patients, they think more is better. So topical
Good point.
steroid, they think if
Yeah.
you use more of it, it'll make it work faster. And that can lead to adverse effects, right? So, with that, a thin layer is generally all you need. So I think telling patients, topical medications aren't necessarily like sunscreen, a thin layer is usually enough. Some patients think that if it's burning, it's working. So they think like irritation,
Yeah.
like, oh, it's attacking whatever the problem is, but
Right.
that might not be what we want, right? You
Yeah.
can
Yeah.
see mild dryness from some products, but again, that severe irritation is not the goal and not what we want them to experience. And then I think, I guess kind of back to steroids one more time. I think we also, on the other side of things, then we have people that are very fearful of them. And they're afraid
Right.
to use
Yes.
steroid creams. So I think just, and especially on children, so, counseling that they're safe when they're used properly. And most of the problems come with prolonged use and with very potent steroids, which we don't generally see over the counter, or if they're using them in places where they shouldn't be. So sensitive areas or thin skin areas.
Absolutely. Yeah. I think those are good. Again, not all topical products are the same. And so helping ensure patients are aware of the product they're using, why they're using it, how to use it, and sticking to it to ensure they're getting the most benefit from it. And then I think too, just calling out those potential ingredients and products that people may have sensitivities to. And as you said, I really like the point of if it's burning, that's not
Yeah.
necessarily a good thing.
Right. We do have some counter irritants over the counter, but we don't always want to.
Right. Right. Yeah. So before we wrap up, is there anything we haven't talked about? Again, this is a challenging topic because we're not focusing on one specific area, but any sort of general considerations we need to be thinking about, especially again, as pharmacists. I think more and more as we're seeing scope of practice expanded in different states, pharmacists are going to be called to action on this. And so anything we didn't get to touch on?
I think honestly that we touched on a lot of it. I think just pharmacists shouldn't be afraid or hesitant really to work with patients on skin conditions. A lot of times they come up against that window and say, here's a rash, and you get a little nervous because what could it be? It could be a whole plethora of disease states. But we're pharmacists and we're helping treat the patient, not just the rash. So even though these skin conditions look similar, talking to the patient, getting that history, sort of understanding what they have and haven't tried, how long it's lasted. I think we're more knowledgeable sometimes than we give ourselves credit for with this, and we can make great recommendations and be great resource for those patients.
I think that's true. I do think, I know speaking for myself, skin conditions is not necessarily something I feel very confident on, but I think you're right from experience that what we've been taught in school, what we've seen in practice, what patients come to us asking about, we do sort of see these patterns, I think, over time, and you sort of do get better at recognizing them. So even though it might be you get a little bit of a concern when that question comes up, the more you dig into those questions that we talked about before, I think that can really help to boost the confidence. So thank you so much, Jamie. Really appreciate this conversation and for sort of digging into this a little bit. It is our Game Changers podcast. So we do always wrap up with what we think is the game changer that we want our listeners to walk away with. So what would you say is that game changer outside of what you just shared? Because I think the pharmacist, having that confidence is super important too, but any other sort of bottom line things to be keeping in mind with this topic?
I think, and this may be reiterating what I just said a little bit, but I think for me, the biggest game changer is that as pharmacists, we don't need to diagnose every rash, but we do need to know common presentations, asking the right questions, and then recommending evidence-based self-care when appropriate. And then obviously recognizing when referral is necessary as well. So, every skin condition is just an opportunity for us to improve a patient's quality of life.
I love that. That's a great game changer. Thank you, Jamie. Thank you so much for your time and for walking us through some of these common scenarios. I really appreciate it.
No, it was wonderful. Thanks for having me. It was fun.
Awesome. Thank you. And we've talked about a lot of great practical tips today. Those will all be summarized in the practice resource that goes along with this podcast. We hope today's conversation gave you something useful to bring back to your practice. That's always our goal. And before you go, be sure to claim your continuing education credit. Your time and engagement count, and we want to make sure you get credit for it. Thank you so much for being part of the Game Changers community. We look forward to a conversation with you all next week.